Good morning, everybody. Thank you very much to the organizing committee for inviting me, and thank you for that nice introduction. I'm not sure exactly what you said, but it sounded very nice. So I'm going to talk about surgical planning of prostate cancer surgery. Super. So this is my institution. It's the fifth tallest building in the hospital in the world, and this is my other hospital. They're two linked. And I first of all would apologize because right opposite from my hospital is the politicians of Great Britain, and I apologize for Brexit. I'm a Remainer, and it's a disaster what's going on. So please, I really hope it works out. I hope we remain. So I'll put that on the cards on the table to start with. So moving on from horrible politics. You've kindly mentioned this paper, and this is essentially probably what everything stemmed from, quality assurance of prostate cancer surgery. And it did lead from this big drive to improve outcomes. If you have the politicians behind you, forgetting Brexit, if you have the politicians behind you, you can have a great change in care. It's a little bit easier, I think, in the UK where we have a National Health Service. Because you can demand change, and unfortunately, clinicians have to change. So we looked at this. There were many providers doing prostate cancer surgery in London. 9 very small hospitals doing less than 10 cases a year, and so we decided to centralize those all into one center. The smaller surgical centers downgraded to become really good diagnostic centers. They were excellent diagnostic centers, but they didn't do the prostate cancer surgery. So we worked in a hub and spoke model. And the main thing was to try and improve care for prostate cancer patients. And that stemmed from the idea that high volume surgeons tend to get better outcomes. There's a lot of data out there to say that high volume surgeons get better outcomes. One of the big disruptors of healthcare models is technology, and as well as the political will, only one of the hospitals in London had the robot, and the robot was one of the things that drove change. So it's very interesting that when you bring in new technology, if you're the hospital that has that technology, it can completely change the pathways in healthcare, and I'm sure the robot had a huge impact on patients coming to us. And I think that's seen around the world. When institutions get new technologies, patients start to come in. So we had this quality assurance program, and it was based on image-based planning of prostate cancer surgery, which I'm going to talk to you about today, and then monthly peer review of surgeons' outcomes. So I'm sure many of you know Atul Gawande. He's a bit of a hero of mine. I think he's a fantastic clinician and academic, and he's based in Boston. And he was the brains behind the WHO checklist, which has been demonstrated to improve outcomes across the world. And so we thought we would try and bring in this checklist for patients having prostate cancer surgery. So we brought in this surgical planning checklist. And so we would, once a week, go through all our operations. We'd sit down with surgeons and radiologists and pathologists and essentially draw up a plan of how the surgeon was going to execute the surgery. And that would be documented in our surgical planning sheets. So it had basic details about the stage and grade, the other characteristics such as previous hernias, lap hernias, open hernias, previous abdominal surgery. And then we get down into the nitty-gritty of the biopsies. And diagrams are key. When you're operating, you need to have very simplistic diagrams to be able to help you incorporate that into how you're going to do the surgery. So we're quite lucky. Virtually all our patients have quite detailed perineal mapping biopsies, certainly targeted biopsies, but all perineal biopsies. And they're documented on one side. And then over the course of the meeting, we generate a surgical plan based on MRI. I think I haven't operated on a patient without an MRI scan for many years, so they virtually all have MRI scans. And we divide this plan about how I'm going to do the operation. We develop the Briganti score to work out whether we're going to do lymph nodes, etc. Sometimes we incorporate the PET imaging. Many patients for high-risk disease have PET imaging and PET MR now. And the PET-MR is also included in our surgical plan to help with the specifics with the node dissection. And we decide whether we're going to do nerve sparing on the right and left. This has gone through multiple iterations, and now we're virtually always including things such as the maximum urethral length. In fact, just last week, we actually cancelled a patient, a 70-year-old patient, who was all due for surgery. His maximum urethral length was 8 millimeters, and we decided he'd be much better going for radiation than a surgical approach. So we're including things like maximal urethral length. The extent of the intra and extra prostatic sphincter is really key, because if you've got a very large component of the sphincter which is intraprostatic, we would then make sure that the apical dissection is altered in the time of the surgery. We talk about the apical dimensions, so if there's an anterior overhang or underhang or posterior lip, these are the key aspects that are brought up in this surgical plan to maximize the cancer and the functional outcomes. I do a lot of salvage surgery. Once or twice a week I'll do a salvage prostatectomy, and then we're talking about the extent of tethering between the rectum, whether there's tethering at the apex, the amount of scarring posteriorly, the degree of fibrosis between the prostate and the pelvic side wall. So these are the things, and every couple of months we review and add data items and then remove them again if we don't think they're particularly helpful. Documents are key, and this map is then attached to the robot while we're doing the operation. And the next point, once you've got your plan, comes from this issue of the WHO checklist. So I'm sure you're all using the WHO checklist on a daily basis to identify your patient, identify issues such as allergies and things. This surgical planning sheet is attached to the robot. And we have these surgical pauses. So whilst I'm doing the operation, we'll actually stop and take a look at this surgical plan at specific time points. So it will depend on the patient, but the average points of the surgical pause, the time to stop and reflect on the plan, is when you're about to do the seminal vesicle dissection. Because if you're operating on a patient with a T3B tumor or an extensive basal posterior tumor, it's very key to take a stop, a surgical pause, look at the plan, and then proceed so you can adapt your operation to that procedure. Another time to take a surgical pause is once the seminal vesicles are up and you're going to do the posterior dissection and drop Denham-Villiers fascia. In some patients, you may want to be doing an intrafascial nerve spare on, say, the right-hand side, and going extrafascial because you've got a posterior T3 tumor on the left. So again, a surgical pause just before you make that decision to do intra versus extrafascial dissection, which may be different on the right and the left. Then there's another surgical pause, of course, when you're doing your nerve sparing. Make sure, obviously, you get the right side, but you need to know often, are you doing a high nerve release? Or if there's an anterior tumor, you may be doing a low nerve release. Or alternatively, you may be going wide. And when you're doing that nerve spare, you need to know, are you going wide at the base or are you going wide at the apex? And again, the surgical pause before doing the nerve spare allows you to decide exactly how you're going to do the operation. We want to maximize functional outcomes while at the same time maximizing our oncological outcomes. So the surgical pause. And then the thing is, you need to know if you're doing the right thing. So every 6 months, we then review the surgical plans with the radical prostatectomy specimen. So this is a radical prostatectomy specimen. We need to know, are we nerve sparing when we should be nerve sparing? Is the surgical plan saying correct? Are we the nerve spare was the right thing to do? Are we doing too many wide dissections? Are the radiologists saying that's T3 when it's not? So you need this continual audit with the radical prostatectomy specimen. And again, I would ask all the pathologists, if there are any pathologists in the room, they may not appreciate this, but the drawings of the radical prostatectomy specimen are key for you to learn and improve your surgical technique. This is all about drawings before and after before the surgery. The other thing that we do, and I won't go into too much detail because I know Dr. Tilke is going to talk about this, but this is reviewing surgeons' outcomes. So every 6 weeks we sit down, well, every month we look at 6-week continence outcomes using the ICIQ questionnaire. We look at rates of nerve sparing by surgeon. We look at positive margin rates by surgeon. And we look at complication rates, and then our fellows identify the exact bits of the video, the edited video, which correspond to that particular error. So if I've had a positive margin at the apex, we will review the apical dissection and see where I've potentially gone wrong, and we'll marry that up with the surgical plan. So maybe I've spared the urethra, maximal urethral length, gone intraprostatic around the apex of the prostate when I shouldn't have done because there was a big anterior tumor. So we do that on a regular basis. So in our paper, we looked at before and after the introduction of these surgical plans. These are the basic patient demographics, and basically before the introduction of the surgical plans versus after the introduction of the surgical plans. And there's no difference at all in the patient characteristics, the extent of disease, PSA, grade, etc. Have I gone the wrong way? I've gone the wrong way. Fine, super. And then when we looked at our positive margin rate, it hadn't changed before or after the surgical plans. However, our complication rates had dropped, but more importantly, the rate of nerve sparing had dramatically increased. Before the introduction of the surgical plan, we were way too often going wide and not sparing nerves, which is something that was a bad thing. And the other thing is our continence rates, since we started doing the surgical plans, got significantly better. And that may be related to the increased rate of nerve sparing, could have been better apical dissection. But our outcomes for our patients were better. This is just an example of our continence outcomes before the introduction of the surgical plan. There's no learning curve there. Nothing's getting better at all. After the introduction of the surgical plan, our continence with regards to ICIQ was dramatically improving. So this very simplistic thing of drawing up a surgical plan, which everyone in this room could go home and do next week. You could set up a meeting where you go through the radiology and the pathology. This very simple intervention, not high tech, was proven to improve our outcomes. And those findings were highly statistically significant. So. And then what about, okay, we're sparing nerves. Is that impacting on our patients at all? Well, we found our nerve sparing corresponded to a marked improvement in potency following surgery. So not only is the surgical plan allowing us to spare more nerves, we're doing it better, and our patients are getting better erections as a result. So traditional morbidity and mortality is where you learn from your mistakes. Using the edited videos and the surgical planning, you can actually improve by learning from each other. The big issue is that it's very easy to do these sort of things if you're a big unit. So we've got 6 prostate cancer surgeons. I just do prostates. We have 6 surgeons doing prostates. We do about 15 prostatectomies a week, and you can learn from high volume. So one advantage may be that if you're not in a high center, maybe you can link up with multiple different hospitals. You could have these joint meetings where you would surgically plan your cases, just like multidisciplinary meetings to go forward. So you don't necessarily have to be in big units. You could link up with your surrounding hospitals. And this is just to mention, your next speaker wrote a very nice editorial about the paper. So this is the image-guided meeting. So this is my list. I've got 3 robots, which I normally do, 1 salvage, and every week we have a meeting. It lasts about an hour, and we go through with the radiologist and generate all these different surgical plans. And this would be an example of one. This patient has got a large right TZ tumor identified on biopsy. MRI has identified it very carefully. Now, you can see here, according to the surgical plan, we were able to do a bilateral nerve-sparing procedure. This is the tumor beautifully up here. Need that MRI. A transrectal biopsy would have completely missed that. There's the image again. And this is another key image that you needed to determine about this. This is right up at the base of the prostate. So the surgical pause at the time of the seminal vesicle dissection was key here. I didn't want to go too close to the base of the prostate. I wanted to come right off and go really wide at the base. The surgical plan told me what to do. This is another patient, a 56-year-old guy. He'd had a HIFU procedure, left anterior ablation. And again, I was able to realize from the surgical plan there was extensive scarring in the endopelvic fascia. So I did all my dissection on the right-hand side of the prostate and left that scarring and tethering right to the end. And that's just an example of a very scarred prostate. So this is where we look at our pathology and we sit together, all the surgeons together. It's a very inclusive, it's a non-blame culture. And it's not that we hide our outcomes, but when we discuss the individual surgeon's outcomes, it's what we would call, there are rules. We don't go out and tell everyone, well, he's got the best surgical margins or he's got the best continence. It's kept within the group. We report our outcomes as a team. It's not a blame culture type thing. But this is where we look at all our different pathology outcomes. And this would be a key, this would demonstrate how we audited surgical plans. So here you can see very big tumor. And this is the radical prostatectomy specimen, and there's a positive margin. The surgical plan predicted it completely. This is surgeon error. Surgeons should have gone much wider here. It's just to demonstrate that the surgical plan was right, and if we'd followed it properly, we could have had a better outcome for that patient. This is a little bit of data about all our different surgeons on our reviewing our continence rates. And we do this, as I say, in a very open way. So I wouldn't be able to do or have all the data for the paper without helping, with lots and lots of help from all the team. The radiologists are key. You need to become super friendly with your radiologists, buy coffee for them and things. Claire Allen is my radiologist, and Giles Rottenberg's another radiologist. They're absolutely fantastic. They give you these beautiful plans, the maximum urethral length, go wide here, Paul, go tight, nerve spare here. Be careful of a big anterior apical tumor when you're doing the DVC. They're absolutely super, and all I need to do is follow the recipe. And thankfully, I like to follow recipes. And I must say, San Sebastian is one of the most beautiful cities in the world. It is absolutely fantastic. I can't believe how nice the city is. I want to thank you all for inviting me.